Honorable Chairperson, respected teachers, and dear audience, welcome you all to my case-based ECG presentation. Me, Dr. Abdullah Al Mamun, MD Cardiology and IPDI. Welcome you all to my case-based ECG presentation. My case regarding a young gentleman in his early 20s who presented to us with a history of palpitation and shortness of breath for 12 hours. On query, patient gave history of previous episode of same type of symptoms for the last 2 years. On examination, patient was hemodynamically stable with saturation with 94% without supplemental oxygen. He got cyanosis and clubbing on general examination. Precordium seemed to be silent on auscultation. Here is the 12-week surface ECG showing normal standardization and calibration. The rate is about 190 beats per minute. Rhythm seems to be regular. POF seems to be absent, but there is some shots of atrial activity before the QRS complex. And the duration of the QRS complex is slightly wide, but not so wide. It measures about 130 milliseconds. And there is also presence of RBBB and right axis deviation. So the initial impression of this ECG, it's a ECG of regular white complex tachycardia for which the differential diagnosis is SB2 with right bundle branch block, maybe due to pre-existing right bundle branch block or aberrancy. And other important DD is ventricular tachycardia, as it accounts for more than 80% of regular white complex tachycardia. So if we assess our patient clinically present with young patient with recurrent symptoms, which favors the diagnosis as SBT. In this scenario, previous sinus ECG may a clue to differentiate between SBT and VT, but we didn't have this one. And if we look at our ECG, there is no features of AV dissociation like capture with vision beat. And there is no presence of extreme axis deviation, rather presence of right bundle branch block and right axis deviation, which favors the diagnosis of SBT. And there is also absent negative concordance. We apply the Brugada algorithm, and it shows there is presence of RS complex and RS measuring about 60 milliseconds, and there is no evidence, and RSR pattern in VU1 and taller right repeater, and there is also dominant terminal ROF. So this is a supraventricular tachycardia with RBB. The clinical and ECG parameters support this diagnosis. So patient was treated with vagal maneuvers initially and then adenosine and amiodarone. As there is no response, eventually patient was cardioverted to sinus rhythm by synchronous DC cardioversion. Here is the ECG before and after synchronous DC cardioversion. A patient was cardioverted to sinus rhythm, and look at the POF. POF is very tall and peaked, measuring about more than 5 millimeter. And after DC cardioversion, 12-beat surface ECG was recorded, and it shows rhythm was regular, rate is about 100 beats per minute, and POF is tall, broad, and peaked, measuring more than 5 millimeters, which is consistent with Himalayan POF, and there is also presence of right axis deviation and RBBB. So ECG diagnosis are right axis deviation and RBB, which can we make a diagnosis clinically? Yes, we can. There is presence of RBB and right axis deviation is very much consistent with ASD secondum, and on examination, presence of cyanosis and clubbing tells us that there is something more in this ECG. Might be a case of complex congenital heart disease. So X-ray was done, shows huge cardiomegaly with narrow pedicle and oligemic lung field. Echo was done to confirm the diagnosis. Flex view, 2D echo flex view showing RB is right side of the heart is dilated, and apical fourth chamber view shows septal leaflet is apically displaced, and anterior leaflet is thin, slender, and cell-like appearance, and there is huge
time is up.
Thank you, Dr. Mamun. I think you have almost finished your lecture. Now, tell your time.
Please, the ECG. Please show the presentation again.
That is Evistin anomaly with ASD, sir. Rhythm was SBT, white complex tachycardia, which is reverted to sinus rhythm, in which there is presence of Himalayan POF, RBB, right axis deviation.
But what is the confirmatory diagnosis of the ECG? White complex tachycardia. Is it a sinus tachycardia with RBB or atrial tachycardia with RBB or SBT with RBB?
I think it is atrial tachycardia with RBB.
Atrial tachycardia with sir. Dr. Jamil, want to make comments? Yes.
The comment on ECG, that is very important. Yes. Please, tachycardia ECG. Slide, please.
Presentation.
This, sir.
Please, discussion. The thing is, there may be two possibilities. If you see the P waves in inferior leads are positive. So one thing you can rule out, and RBB is persisting. So it cannot be a pathway. For a pathway, second